UK from United States, thank you so much. This is the collaborative meeting between Jintavins Health Foundation, Encapsulate Healthcare Solutions, and Victory Drugs. Thank you for joining. We'll start now. As others come in, they will meet us where we are. First of all, we are going to have a welcome address from the founder of Jintavins Health Foundation. And I'll just share that now.
Good afternoon and welcome. On behalf of the Board of Directors of Jintavins Health Foundation, I welcome you to another of our webinars and health promotion meetings. I hope you will stay all through the meeting. Today we're talking about child health. We know that a lot of diseases start in childhood, and information and taking preventive measures, especially when there are specific risk factors, will prevent illness not only in childhood but in adulthood. If you have a child or have grandchildren and they are not in this meeting, send them the link so that they can join. We have some very distinguished pediatricians today who will talk on some aspects of child health, and there will be ample time for questions at the end of the meeting. We hope you will stay all through the meeting. As usual, our meetings are organized and funded by our ardent facilitators and your donations. Our able project manager, Mr. John Esagbedo, will give you details on how to donate if you are able to support our work. I'll now hand you back to our able moderator, Ms. Flora Coker, and do have a lovely meeting. Thank you very much.
Thank you. Good afternoon. Thank you. Thank you. Great. Thank you, Dr. Agnew, for the welcome. We'll go straight now to our first speaker, and I'll just introduce him. So our first speaker for today is Dr. Olumide Oyefeso. He's a consultant pediatrician. He's a fellow of the American Academy of Pediatrics. He serves the needs of children and families in parts of the US and Canada. He was born in Nigeria and has practiced medicine in Nigeria, the Caribbean, and North America. He has a special passion for children, standing for the underserved, as well as reducing social disparities. He has served on the boards of several hospital systems and charitable foundations. Aside from medicine, he has a passion for entrepreneurship, and he is a team player with a strong focus on synergy and collaboration. He is the founder of For Breath for Life, an organization fighting to save the lives of babies and mothers in underserved countries, especially Nigeria. There is a harrowing statistic that more than 700 babies die in Nigeria every day. And For Breath for Life has taken up the challenge to change that reality. So, make welcome, Dr. Oyefeso. Over to you.
Thank you very much, everyone. It's a pleasure to be here, and I'm so happy with the work that Jintavins is doing, as well as many other people. It's so important for so many of us to work together to improve the life of everyone in Nigeria. And of course, my particular passion is for children. And I'm happy to see my fellow pediatricians here, Dr. Dayo and Dr. Doherty, who you'll be hearing from later as well. I just want to drop some thoughts with you, and also to share, and also I'll be sharing a video with you. I'll try to keep it brief just to leave room potentially for any questions or comments. Essentially, it's very, very important to know that Nigeria has the second highest infant mortality rate in the world. And well, we may be happy in a sense to hear that it seems new data is showing that we're now number 3 instead of number 2. But either way, it's still a very, very bad statistic to have. And also in correlation with that, we also have the second highest maternal mortality rate in the world. I'll tell you that more than 700 babies die in Nigeria every single day. There are a number of reasons why that happens, but essentially at the core of it is that many of our mothers are in a difficult situation whereby they are having to make certain choices that impact the lives of themselves and their babies significantly. Essentially, it's important for a mother to know there are certain questions you will have to ask. where am I going to deliver? When am I going to deliver? How is that delivery going to happen? And who is going to be present at the time of my delivery? It is so important to emphasize that a skilled provider, and when I say skilled provider, be it a doctor, a nurse, a midwife, a community health extension worker, or even a traditional birth attendant, a skilled birth attendant must be present at every delivery, or else many sad things will happen. There's a balance in Yoruba language that says "Ekwe womo," meaning it's a greeting to greet someone for surviving the danger of childbirth. So it is clear that the process of childbirth itself is laden with some risks. So because of that, we have to take adequate steps to protect the life of the mother and the child and reduce this statistic. And also, I will implore all of you, at the end of today, we'll share in the chat there. I'll implore the technical people to share with you the link to this video, and feel free to share it widely. Feel free to talk about it, tell your friends about it. We want mothers to know that they can make better decisions for themselves. So I'm going to play the video. But before I do, I also want to acknowledge the fact that we developed this video with the help of an organization called Black Eye Studios. And in fact, the animator who created the video is actually in the audience as well. And full credit to him and his team and their artistry for putting it together. We find the video very, very compelling, and I hope you enjoy. I'll be sharing my screen so that we can look at it, and then afterwards we can invite questions and comments. I don't want to take too much time because I have more important pediatricians who are smarter than me that I'll be talking to you. Can you all see my screen? If anyone there can give me a thumbs up. Screen. Okay, here we go. Yeah, thank you very, very much for your attention. And there's so many things we can say concerning this video, but I'll leave room now for questions and comments. And thank you very much, and thanks to the organizers for having me. Much appreciated.
Thank you so much, Dr. Olumide. What a very powerful and, in fact, impactful video. Do we have any questions for Dr. Olumide? You can pop it in the chat or raise your hand if you want to ask him any questions. Okay, if you're still thinking about it, he'll still be here. You can ask him later if you think of any questions you'd like to ask him, and then we'll come back to that. Thank you. All right, so we'll go straight to our next speaker for today. And her name is Dr. Orode Dorothy. She's a US board certified pediatrician and public health physician. She's the founder and medical director of Ingress Health Partners. And there she is working on expanding integrated comprehensive primary health care, employing a continuity of care model and incorporating anticipatory guidance and behavior change at community level. At Ingress Health Partners, Dr. Dorothy leads a team of dedicated professionals who engage in high-density communities around maternal and newborn care. They work with local traditional birth attendants and maternity homes to improve referral patterns and establish safe pregnancy and newborn care practices. Her 29-year professional career has spanned clinical and academic pediatrics, health and hospital system strengthening, community development, establishing livelihoods, and the promotion of life skills in women and young people. She's a fellow and a moderator of the Africa Leadership Initiative, West Africa, and Aspen Global Leadership Network. She holds a master's in public health, maternal and child health from Harvard University School of Public Health. Dr. Orode, over to you.
Hi, everyone. Good afternoon. I hope you can all hear me clearly.
Yes.
I've been at another event, and I apologize because I'm running up and down, literally like an ant in a sugar box. But I'm just going to share my screen and hopefully not run through the presentation, but walk through it. Okay, so it's saying screen share has failed to start. I don't know what that means.
It's coming up now.
Yeah, but it's showing the wrong screen. All right, so
try again. Yeah.
Right, excellent. Okay, everyone, thank you very much to the Jintavin Foundation for having us. I like to think of myself as somebody who is really focusing on newborn care. Because much of the work that we've done in the past few years has really exposed us to the concerns around the newborn period and the issues that mothers face. And so even though I'm going to be focused on the newborn period, Dr. Ajayi Obey, my senior, who comes after me, is going to be speaking about the other issues we see in the first year of life. But by and large, some of these things will cross from one to the next. So at the end of this conversation, these are the things that I hope that you will have a good idea of how we define what to expect, some common conditions, and then red flags, and when mothers, and some of mothers frequently ask questions. So the newborn period is the first 28 days of life, and infancy is the first year of life. Straightforward. I love this book, The Normal Child, because it reminded me of all the reasons why I wanted to study child health. I think of myself as a pediatrician, but somebody who studied child health, because I don't only think of all of us working in the sphere of sick children, but in the sphere of well children. And I think it's important for you to understand what's normal in a newborn in order for you to then say, oh, this is out of place. This is not right. So this is one of sort of my favorite quotes I share with people whenever we talk about young children. The full-term newborn sleeps for the greater part of 24 hours, yawns, hiccups, sneezes, coughs, stretches, and salivates. Basically, he's a human. He can suck and swallow, smell, taste, and hear, lies with his arms and legs flexed in the prone position, lies with his knees drawn up under the abdomen with the pelvis high, his head is turned to one side. I like to also remind mothers of the newborn behaviors to be aware of. They sleep for very long. They can have short naps. They have small stomachs, so they need to feed very frequently. And sometimes when they're in the third stage of sleep, they look as though something bad is happening. And so when moms say, I have to show you a video of what my baby is doing, I think it's convulsing. And we say, oh, that's normal. And it's important to know normal. Teach mothers normal so that they know normal and they can identify abnormal. Another one is the breathing, periodic breathing, the normal pattern. They can breathe very fast, very quickly for about 10, 15 seconds, and they appear to stop breathing for about 10 seconds, and then they begin again very rapidly, up to 10, 15 seconds again. The most important thing is that they should not pause for longer than 10 seconds. And so that they're breathing normally, right? So I see this all the time. I have little videos of moms saying, my baby is doing this and that. First week of life, what happens? Babies may lift their heads briefly, and we teach everyone to start tummy time as soon as they can. They can focus within 8 to 15 inches. Body hair is present. The more premature the baby, the more likely they will have body hair. And then they will have some swelling of the labia and the eyelid and the scrotum, which will all go down in the first week. Second week, feed, change, rock, sleep, poop, repeat. And all they do in the second week is poop and more poop. The cord starts to fall off, and they may regain their birth weight. We hope they do. If they don't, that's an abnormal. That's a deviation from normal, and we do something. In the third week, they start to look more like a baby, sleeping a little longer as well. They increasing tummy time if you do the right thing with them. And we say, try to teach them the difference between day and night. It may not happen. By the fourth week, of course, children may begin to respond to loud noises. They may startle, and the mother tells you, he starts to do this. And it may be that moms begin to be able to decode their cries. They may start to do what we say cluster feeding, where they feed, and then they sort of sleep for like 2.5 hours, and then they do this feed again. And it is at this time we start to check in on mothers and find out what's going on with them. How are they feeling? Are they feeling weepy, sleepy, crying? They don't want to hold the baby, and how their nipples doing, because we're breastfeeding advocates. So what's the most important thing? I tell everyone, wash your hands, wash your hands, wash your hands. Continually wash your hands. Take out all those nice fancy long nails. They are good for the wedding. They're not good for the newborn. Chlorhexidine for the cord and or methylated spirit. In Nigeria now, we're pushing for chlorhexidine, but we don't always have it present. And we certainly encourage moms to buy it as part of the birth kit. But if they don't, that's fine. Methylated spirit while they're in hospital. Teach them how to clean with every diaper change and at least every 2.5 hours. Circumcision care, rinse off every poop and pee. Many people will start with Vaseline ointments, penicillin ointment initially, and then I always advocate large dollops of Vaseline because, it's just great. It's the greatest healer, the greatest thing I've ever come across in my life. First, certainly in my both in my professional life as well as in my life as a mother. And so I advocate Vaseline on the circumcised penis just as soon as the 24-hour period is over, when initially they had penicillin in many places. Okay. The cord we talked about, chlorhexidine, don't soak in a bath, don't help remove the cord. I have mothers who use something they call everlasting, I forget the name of it, I'll remember in a minute, which they used to shrivel the cord in 24 hours. don't advocate it, right? And always try to ensure that the diaper is folded underneath the cord, allow the cord to fold. I don't like to talk about brands very much, but like I mentioned before, Vaseline is the thing for me. I like to advocate gentle soap, Dove soap, obviously, virgin olive oil, because it's very helpful. And these things solve a variety of problems in the first month of life. Usually, these rashes will go away. Everybody wants their baby to look like a Pierre's baby the moment they're born. They don't look like that. They're actually quite scrunchy and very red and splotchy. But, you know, our moms start to try to use creams early, and we try to ensure that they're not doing so. Okay? All these things in the newborn period. Thick dandruff, red mark at the back of the neck, splotches on my baby's face, tiny white spots on my baby's nose. When is it going to become smooth? All of these things. I've had, you know, moms say, is this measles in a child who is, you know, literally 3 days old because of erythema toxicum neonatorum. But these are the things that I think really bother moms a lot. Infantile seborrheic dermatitis, we call it ELA in Yoruba, ELA in Igbo, and it's chronic inflammatory skin disease. Let me not call it a disease, it's a condition. It usually disappears by the end of the first year of life. It's scaly in some instances, a little greasy, but every baby, you know, 7 in 10 babies get it. And we just teach moms it's harmless. I know the real reason is that when it affects their faces, moms are very disturbed about taking photographs. If it's on the body, they don't mind so much, but on the face, oh my God, it interferes with their ability to take pictures. And what we usually just try and calm them down and say, it's going to disappear. Your baby is not always going to look like this. I tell them I had the worst case of ELA anybody has ever seen in their lives, dandruff and everything. But it cleared, it completely went away. So if I came out, you know, looking half normal, I'm sure your baby will be fine. We don't know why it happens, but we think that there's some yeast growth on the skin that interferes with the naturally occurring oils on the skin. And then in some babies, presence of maternal hormones. The most important thing is that it will disappear. But for the babies and the moms who really insist on something, then we give them one-on-one care and we address their issues. Where they really have an issue, it's when it's on the scalp. And I've gone through that with my babies, really thick, difficult cradle cap. And we say, you know what? Just use a little brush every day. And after you put in some olive oil or some baby oil, and just brush at the bottom of it. And when that's done, then shampoo, and just mild shampoo, and continue to do that until it goes away. Right? So I shown this picture because this is it happens to many moms where they have the cradle cap and they have the really dry skin and they think, oh my God, my baby's a monster. And, you know, everything is looking horrible. But guess what? This is a little girl. Guess what? It all goes away with time. We just say, use gentle soap, use Vaseline, lock in the moisture. So after you're done with giving a bath every day, just gently dab their skin dry. Apply Vaseline to lock in the moisture. So don't rub the skin because it's dry and it's easily abraded. You know, it's newborn skin. And then lock in the moisture with Vaseline. And babies look bright as rain just within 3 to 5 days. And a lot of the time they come back. And I was saying I couldn't share a post picture because in the post pictures, they're always like, oh, her skin is beautiful. And they're showing the baby's face and they never show the problem area anymore. But, you know, it's fine as long as everybody is happy. We talked about how to get rid of what's on the scalp. Impetigo is actually the most common skin infection in children. It's highly contagious and primarily caused by staph and strep. Can be bullous or non-bullous. So in this child, what we see here is all these little lesions. And then there's her little, you know, she's got some lanugo, she's newborn. She also got some of her skin hasn't gone away. You can see all her beautiful, rich, beautiful hair. Very frustrating for moms. They don't know what to do. It's very simple. Bullous and non-bullous. So the bullous tends to affect the infants and young children. We see this, what she has, fragile, thin roof, flaccid, transparent bulla, and they rupture and they leave a rim of scale, but they don't crust, right? And then these ones that are less contagious than the ones that are the non-crusting kind. The non-bullous impetigo actually is the one that's a crusting kind that is, we call it impetigo contagiosa, because I mean, all you need is for one to be here, and you know, if the skin, if it bursts and gets onto the next part of the skin, they'll catch it as well. So it's spread very easily to other parts of the body through touch, clothing, and towels. And the pustules quickly rupture, ooze, and then form a crust, and they spread, right? Those ones, itching and soreness, are generally mild. In those ones, they tend to happen on the face as well. In older children, what do we do? Wash your hands. The best thing you can do when you have a newborn in the house is keep washing your hands, and then make sure that you're moisturizing as well, because you don't want your skin to break. Daily soap baths. We do something called a Milton rinse or a wipe down, and dermatology likes this because it's a bleach bath, really. It's just a quarter tablet of Milton, which every young mother has or has come across and knows where to find, because they buy them in the baby stores, and put in a large bowl of water. And then after the baby has had a bath, just do a rinse, just pour it gently and definitely over the baby's skin. And do that every day. Sometimes, depending on how severe, we say they should do it twice a day. In some children, where it's a very localized thing, we do a Milton wipe down. So the same, dip the Milton tablets inside the water, and then just a muslin cloth, and just wipe over the area. And then sometimes we use topical antibiotics, oral antibiotics, and always emollients for skincare. I love Vaseline. I'm very open about that. I don't hide it. But moms like all the other things that E45 or Oilate, whatever it is that works for you, we're fine with. Just trying to find my cursor here. I'll run through exclusive breastfeeding. I think the most important thing about breastfeeding is that moms should know that it offers them the best possible start for children. So for mothers who can breastfeed, and by all means, they should. It's just giving no other food or drink, not even water, and breastfeeding the baby on demand. That's what exclusive breastfeeding is. We like the golden hour, because during the golden hour is the first hour of life. And if babies are able to latch on in the first hour and suck even for all of 3 minutes, it changes significantly the disposition of that baby around breastfeeding. It helps the mother, it helps the baby, brings forth the colostrum, which is all the wonderful antibiotics. And it, soon after they're born, they go into this long sleep. Then when they wake up, they're screaming, everybody's anxious, and the mom's trying to put baby to breast, we've lost the opportunity. So the best thing to do is the first time, as soon as baby is out, healthy baby, crying, screaming, put to breast, and catch the opportunity to get some colostrum, okay? We say breastfeed on demand. I'm going to run through these. Expect the appetite surge between the 5th and 10th days of life. Baby's going to scream. Just take your time, and more milk is coming in. Just keep putting baby to breast. More frequent is more important than this time, please. Every time baby goes, put the baby to breast and get on with it. Because the more frequently they breastfeed, the more likely that they're well stimulated and there's more production. Okay, we talked about skin to skin, really important. It's a good way of keeping babies warm. It's a fabulous way of making sure that baby and mother are bonding and encourages baby to latch on. A lot of babies have a lot of spitting up. They encourage moms in between, stop, burp baby, and come back. Again, frequency of feeds are more important than length of feeds in the early days. They don't have to feed for 20 minutes, but in the beginning, they should certainly be coming very frequently to the breast. Expect the initial weight loss. They'll regain their birth weight hopefully by 10 to 14 days, and we expect them to be about 1 pound above their birth weights by the end of the first month. Now, if poop is green, and that's very common, it just means baby is most likely not getting enough of the hind milk. As they get a little older, you will find that, so in the beginning, early days, having 8 to 12 diapers a day, they slow down a little bit and it's looking like a goosey. And then if it starts to get green, it means that the baby is probably not feeding for as long as baby should. Because in the beginning, plenty of water, and then later on in the breast milk, you find the hind milk, which is richer, thicker, it's got more protein, more fats, more calories. And so if babies are not getting enough of the hind milk, they're more likely then to be not getting enough food. And that's why the poop turns green. So some of the problems we see, I always think of, categorizing when you think about newborn, first, second, third, and fourth week. So jaundice in the first week, heart problems in the second week, third week, that's when colic sets in. And we'll talk a little bit about colic, and then cluster feedings in week 4. The baby is hungry. The baby doesn't want the breast. Breast is not enough for baby. Why should we bring babies back if they have a high temperature? So if it's rectal temperature is greater than 38.3 degrees centigrade, baby is unusually cold, breathing very fast, or has noisy breathing. Baby is not waking up to feed. Where baby has normally woken up every 90 to 120 minutes to feed, and baby is just snoozing and not waking up. And even when they wake up, they're pokey and they're not doing anything, or the baby is floppy and baby is not really doing anything that baby would normally do. Or if you find that the baby is crying inconsolably, babies who just cry, you can't stop them, just bring them in. Even if it's colic, just bring them in. We'll figure it out. And then if the baby is fine, you go home with the baby. We'll tell you what to do with the baby. Babies who are vomiting, especially if they're vomiting alone, or babies who are vomiting with diarrhea, because we don't want that them to get dehydrated, and they can dehydrate very quickly. And then babies who develop jaundice, yellow eyes, palms, or soles. The most important thing about jaundice, in addition to the fact that it's yellow skin, yellow eyes, is that it happens in most babies, but we won't know whose jaundice is the bad kind of jaundice unless we see the baby and we measure the levels. So when we have the opportunity to do a screen on the forehead, we do the screen within 24 hours, we do it again at 48 hours, and by 72 before they discharge, depending on where the baby is born. So some babies won't have all of this, and we just want to see the baby and get a bilirubin level. So for moms on the call, why do we care? It's because when the bilirubin levels are high, it can cause problems. It can cause, when they're dangerously high, it can cause cerebral palsy. Something called kernicterus, which is when bilirubin levels get so high, they cross into the brain and they cause cerebral palsy in children, where you find that children later on in life have problems of motion. Some of them have difficulty swallowing. Some of them have delayed speech and so on. Can also cause hearing loss. And so we want to see every baby who's jaundiced. We want to check their bilirubin levels. And then we want to be able to tell you, based on the age of the baby and the level of the bilirubin, this is physiologic, means you can go home. This is pathologic, means you stay in hospital. And then we do one of several things. Okay? I won't go into details about this. The most important thing, allow the doctor and or the nurse to examine your baby and to get a bilirubin level. Once we know what the levels are, then we can make a determination what needs to be done. And it can be any one of these things. It can be that baby has to go under the lights. We want to continue to breastfeed. We can wrap the baby in a baby blanket. We can do an exchange blood transfusion. All of these things are to bring the harmful bilirubin levels down into harmless physiologic levels. Mommy and baby can go home and continue to feed and do their best. So I just wanted to make sure that nobody was trying to send me a message. All right. This is the commonest rash you will find in newborns. Every mother wants to get rid of this rash in the first week of life. I tell them, it will go away. It will just completely disappear. It's called erythema toxicum unitorum, big name for a very small thing, which we don't know why it happens, but it's just red blotches, and it can happen all over the body. And nobody wants to take a baby with a blotch everywhere. I came to have a fine baby and it's supposed to be perfect skin. It doesn't happen. I've not seen a perfect skinned baby on the day of life and for the first 4 weeks. Every time there's something going on, and that's fine. The most important thing about this is that it goes away completely. Doesn't need any treatment. And so this is where we find moms start to use different things, from Bacta and dangerous things. Don't touch the baby's skin in the first month of life. If there's anything going on, use Vaseline, okay? This is also quite an issue, and it's because of the blocked tear duct. So what we call the lacrimal gland, this is the tear duct, the tear gland. It produces tears, and it sits right here above the eye. And then it releases its liquid into these two areas, above and below. These punta, it's not labeled here. And then they go into the tear duct, which sits on the side of the nose of the baby, which is right here. So if this thing gets blocked for any reason, if this duct is blocked for any reason, it will push back and fluid will come out. And sometimes it gets pussy. So we just tell moms, just use a clean washcloth or a cotton ball, warm water, make sure you've washed your hands, wipe the baby's eyes, wipe, have the baby, well, baby will close their eyes once you start to come close. And then just from the inside to the outside corners, gently wipe from the inside to the outside, 3 to 5 times each time. It's called a massage. And then a different cotton ball for each eye. And usually it will go away. Some babies have it recurrent. We just teach mom how to massage the blocked tear duct. As they get older, the ducts open and they get better. This is very common. Infant cough and catarrh usually is due to an older sibling who's brought a virus home when baby goes first time in daycare. I'm talking about this now because Dr. Daya and I had agreed that I should talk about this infant cough and catarrh. But sometimes also, this is the beginning of allergies and reactive airways disease, right? So what you must remember to do is that you can take the baby into a steamed bathroom or boil a kettle in a small room and take the baby in there, and it allows baby's airway. Just think about how when you've just had pepper soup, the way your airway is clear, same thing, right? The easiest breathing, then you allow the baby to nurse and everybody calms down. We also advocate saline drops. Drops will help clear congestion, can follow with gentle bulb suction to clear. Vitamin C drops, a humidifier in the baby's room if it helps. Remember that if you have a humidifier in the room, you may need one of those dehumidifiers if you are prone to getting mold in your home, which is another reason why babies could be coughing. So you have to strike the right balance. The dust, I tell everyone, if baby starts doing this thing over and over again, just remove rugs, carpets, curtains, and just replace with blinds, and as much as you can, take all these things out of babies' rooms. They don't need those things. Those things are for us, not for them. Avoid cough syrups, Piriton, everybody loves them. Everybody gives antibiotics. And as we give antibiotics, we come on to the poopy rash. We'll talk about that, and continue breastfeeding and give as much as we can in terms of fluids, especially breastfeeding if they're under 6 months, and then other fluids as they get older. And then when they're fussy, give paracetamol. Remember, baby has a high fever, bring baby to hospital. In our part of the world, they can have a cough, they can have catarrh, but we must also make sure they're not carrying, they may have a virus, we must make sure that they're not carrying a bacterial infection. A blood count will show us that. We'll do a malaria check as well. And sometimes these things coexist, sometimes they don't. A really common question moms ask, when do they start sleeping through the night? And I tell moms, without meaning for them to feed their babies fats, after they attain a weight of 6 kilograms, they can tend to sleep for 6 hours at night. So I had a mom who 2 days ago said, oh, she's sleeping through the night. I don't know what to do. And I said, sleep through the night is good. It's not a bad thing. She's worried. But that baby has attained 6 kg. Her stomach can hold more food, and she can now sleep through the night. Usually it's after the age of 3 months. So between the second and the third immunization for us in Nigeria, it doesn't happen to as many babies as it should at this early. And some of this is because of the habits of the parents. So it's not only the babies that help themselves sleep through the night, the habits of parents as well. What's colic? It's the thing that makes everybody come in around from the 3rd week of life. Baby is otherwise well, baby is healthy, and then just starts to scream blue murder for several hours. And it's usually in the evening when everybody's tired and everybody's getting ready to go to bed. And they are screaming and they're inconsolable. And when they have this colicky scream, let me tell you, if you've never had it, thank God. Because if you've had it once, you will never forget it. It sounds as if someone is trying to kill them. They're screaming and they almost don't take a breath in between these screams. It's scary, especially for first-time mothers. And so we teach moms what to do. Turn on a white noise source. It can be you buzzing in their ears. It can be a fan in the background. Rock your baby, hold, swaddle. After you've checked they're dry, there's no poop in the diaper, there's no irritating diaper causing them to scream. Baby is fine. So you can swaddle. I usually send mothers a video on how to swaddle. Or you can put the baby on your outstretched arm, let the legs dangle, and hold the chin up right here. I hope you can all see me. Hold the chin up here, tip the face up with the chin like this, and just rock the baby like this. I don't know why that thing happens. I don't know what it does, but something happens and some of them fall asleep. Some of them, they need a warm cloth on their belly or a massage of the belly. So sometimes we put a warm cloth underneath, put the baby on with the belly down like this, do this thing. I don't know, it works. And for the ones that where it doesn't work, do the white noise, do the hand up and down. When it's not working, hand off to the next adult. Please do not shake your baby. Please do not shake your baby. If there's no other adult, there's no problem. Baby is safe, baby is healthy. You swallow, they're screaming, they're fine. Put the baby down, walk away. Don't give in to the impulse to shake or to, let the baby realize that something is happening. No, nothing is happening. Just put the baby down. We're also learning that if moms are able to reduce their caffeine and their spicy food and alcohol, which we are hoping that they're not drinking, but if they reduce those, it may help. Okay, very painful. Isn't it very painful looking? It looks very painful. It looks very scary. But this is due to prolonged contact of the baby's skin with poop or pee. Diapers not changed quickly enough. Expose, we may need to treat, but usually if you just expose frequently enough and then you put a diaper cream, a barrier cream, and you change the diapers more frequently, it goes away. Sometimes they need to be treated with an antifungal. I'm going to stop here because I didn't want to overshoot my time, and I already have. But we're seeing a few cases of children now who are getting diaper rash. We think it's from diaper content. And we're trying to figure out how to do it, how to manage it. But we're doing all the things that we normally would do with babies to help with the diaper rash. I'll stop right here and I will take questions if there are any. And I do apologize if I have overshot my time. I will be with you in the background. Thank you.
Thank you so much, Dr. Orode. Any questions for Dr. Orode? When you were talking about coughs and catarrh and cold, you mentioned about antibiotics, but I just wanted you to emphasize it again that you were saying to avoid, not to use. Yes? Oh, you're on mute, 1 second.
Right. So the doctors should usually make the determination whether there's a need for antibiotics or not. Children will get 6 to 8 colds in the first year of life. There's no need for antibiotics most of the time. If there's going to be a need for an antibiotic, it has to be diagnosed by a doctor. However, I'm finding that almost every baby who goes in gets antibiotic and anti-malarial, and I don't know what we are treating. So I encourage moms, do everything you can to take care of the baby at home. If a fever sets in and is not coming down, then by all means, take the baby in. But in the absence of a fever with a cold, dedust and do all the other supportive things. But, don't try and get, my people, now, we buy antibiotics quickly. But we should stop that practice. We're in a dangerous place in Nigeria where we've lost most of our antibiotics now. We're using the big guns now.
Thank you. Thank you. Dr. Olumide, you wanted to make a comment?
Yeah, thank you, Dr. Doherty, for a beautiful presentation. Even though I'm a pediatrician myself, I learned quite a bit. So maybe I should come for more tutelage from you. Excellent job. Thank you very much. I also thought I practice in North America, I practice in Canada. And of course, babies are babies all over the world. So a lot of similarities and some peculiarities at the same time. I just wondered, it might be in existence. I would just wonder, just a thought for you and other folks like us. I thought it might be interesting if we actually created just a simple pamphlet, a simple educational pamphlet. I'm sure many hospitals in isolated spots do that. But a disseminated pamphlets that mothers can have that says that these are things to have, to watch out for. These are danger signals, when to go to the hospital. Very brief and to the point, widely disseminated so that many mothers have it and so that they know, and also being conscious of, language barriers and literacy levels as well. I thought that might be something to explore. Then my other comment briefly is, oftentimes when we're talking to moms about reassuring them regarding many of these newborn rashes, sometimes in spite of your best efforts, they can't be reassured because women are so, obsessed about perfect looking skin. So I had a kid many years ago, sometime in 2010, with a terrible eczema, which went on to be with a super infection. The child at the same time was infected with eczema, with epizoster, so had eczema epitheticum, and at the same time had what we call MRSA, staph. So there's a bacteria called staph. So this child had a viral infection and a bacterial infection at the same time on an eczema skin. So I'll just share my screen real quickly. And I often share that with, and we actually did an article on it and published in one of our journals way back then. I hope you can see my screen. And you can see this child's face. So when moms are complaining and all that, sometimes I'll show them this picture to tell them that it's not that bad. This is how bad it can be, and oftentimes that helps to reassure them. Thank you for your presentation.
Thank you. With regard to the pamphlets, so there are pamphlets in existence. But what we found though is that many of our young mothers are actually turning to virtual opportunities. So people are posting virtually what you can do for everything. And moms will go out there on Instagram. They're also checking. So I think we need to sort of respond also to, I think in the US, they used to give us, going home instructions. I don't know that they do consistently here. In some hospitals, some of the higher end hospitals, they do. But by and large, one of the ways we can get to women is we can push all of this information out on Instagram, and there are very many resources where women go to check. And we, of course, we run a virtual anticipatory care guidance intervention. And so that's another way. But yes, it's well taken. The point is well taken. It's just by the time you put something in a pamphlet and print it, some of those things are out of date. So you really want to also be keeping up with the times. Thank you for that.
Thank you.
I'm responding to a couple of questions.
Yes, please. Can you do it here? Yeah.
So, there are a lot of these things that contain either alcohol or Benadryl or Piriton. Some of these things are dangerous for young children. And we do not, even the manufacturers of these drugs will write it on that they do not give under the age of 6. So when you're not on 6 years, so when you now have a drug that contains one of these, something, and then Benadryl or Piriton, it's not safe for children at this age. So, it's not so much a standard. It is, once you've seen one bad outcome, like Dr. Lumide just shared with you, once you've seen one child stop breathing because they got one of these drugs, you will be very clear in your mind that you're not going to use those drugs for children of this age. Same thing for management of colic. So we found that there's no evidence for most of these things that we do. There's a drug out now. Some people say, oh, well, I said, well, let's test it. Let's let mothers start using it. It's got nothing but simethicone in it. And if that's what they're going to use, that's fine. But that mother has to understand that there are side effects to those drugs, and she needs to be able to go into the hospital. And she should, first of all, give all of these other forms of care the benefits of the doubt. Because if you make the mistake of giving the wrong child a drug that can cause problems, as a pediatrician, you can't live with yourself. As a mother, I can't imagine what that would be like. So we're just careful to say, here's a way to help your baby. And if it's too much for you, trust me, the baby is not suffering, hand the baby to another person and go to another room.
Thank you, Dr. Orede. Okay, there are no more questions at the moment, but I'm sure there will be later, and we'll take that in the Q&A panel. So we'll go on to the next speaker so you can. Thank you. All right. We're going to go to our next speaker now. And her name is Dr. Dayo Ajayobe. She's a senior consultant pediatrician with an interest in infectious diseases, immunological disorders, and complex pediatric conditions. She's a thought leader and strategist who has worked at the Hammersmith Hospital, Imperial College, Healthcare NHS Trust in the UK for about 2 decades. She's also worked in the private sector, where she was appointed at the HCA Chiswick and Imperial College Private Healthcare. She also played an instrumental role in the evolution of pediatric ambulatory services in the UK, which was jointly pioneered with other organizations, and that model has been taken forward by other organizations within the UK. She's also an independent non-executive director at AXA Mansard, with HMO board in Nigeria. She's a trustee on the Meningitis Research Foundation UK board and just completed a 3-year term as an elected counselor on the Harvard T.H. Chan School of Public Health Alumni Association in the USA. She also has a keen interest in climate sustainability. Dr. Ajayi Obe, over to you. Should be able to unmute. Yeah, there we go.
Okay,
Perfect.
Good afternoon, ladies and gentlemen, all of you here. I'm Dr. Ajayi Obe. Thank you very much, Flora, and thank you very much, Dr. Agun, for inviting me to this August occasion, where I can share my experience. And I'm hoping that at least we'll be able to make things easier for parents. Thank you very much, Dr. Yepeso and Dr. Rode, for going ahead of me to make it easier for me as I share my slides. Now I'm talking about some common conditions in children under the age of 1 and toddlers as well. And I'll start with immunity. Children are actually prone to infections. Usually in the first couple of, like already has talked about the common conditions that happen in babies. But after that, babies tend to be pretty much protected. But I'd like to share the reason for why children are actually more prone to infections as they grow older. In the last trimester of pregnancy, which is between 6 and 9 months, moms transfer the antibodies, which are units of immunity, that passes through the placenta and moves into the baby. And therefore that baby is born with some level of immunity, which is mom's immunity. Secondly, when it comes to colostrum, already talked about the colostrum, that colostrum is rich in antibodies as well. And it's important that mothers make sure they take advantage of that. If you're born preterm, so if you're born at 28 weeks, 7 months, or you're born even earlier, you lose that ability to get that immunity from the mom. And so these babies are actually more prone to infections. And so at least the colostrum, we need to get it in to make sure that this child has a good start in life. The world is full of bugs, and they're waiting to, crash onto this baby who is nice, clean, and ready. Well, most babies are nice and clean, ready to move on. And immunization schedules. So when the antibodies kick in, mom's immunity covers the baby, but it starts to wane over the next couple of months. And that's why we kick in these vaccines. You will see that we're all pretty good. Nigeria's actually pretty good. We immunize 12 diseases. UK immunizes against 14, the US 14 and US 14. They're a bit different in that Nigeria covers yellow fever and TB, and also tuberculosis, and also meningococcal meningitis, which arrives every year up in the north, but sometimes comes all the way down to Oyo State as well. Varicella, the chickenpox vaccine, the US and Canada give it. The UK does not give the varicella vaccine. So just give you an idea that immunizations are important to protect children from infections. It's key. I know that the non-vaccinators who don't want vaccinating, but I always tell them, I am able to sit down and negotiate with them. I say, nobody wants meningitis, so you better get this meningococcal meningitis, this first vaccines. Do you travel? I ask, do you travel? Because most of them are highly educated. I say, go to exhausting areas of the world. You're going to be more prone to TB and so on, these nasty infections, you better get your vaccines. So if you actually engage with your parents, I tend to engage with the parents and tell them, break it all down, then it's more likely to understand the risks and to get this vaccine given. Fevers. I'm going to talk about fevers in children. When a child feels hot, miserable, tired, a temperature of above 37.5 is a temperature. Yes, 38, above 38, we get a bit worried, but anything above 37.5 on a thermometer, practically under the arm, is the temperature. Most fevers are due to viruses and other germs responsible, such as bacteria, parasites, and fungi. But viruses, we tend to be able to deal with them quite a bit. I mean, COVID, of course, came full on, but at the end, there wasn't any treatment for COVID. It was just wearing it, just letting it pass by. So most viruses for children, it runs through and they get better with time. So as I said, fevers in children, Jenny said 7.5. Most fevers are viruses, and we've said that again. The common fevers, cause of fevers in children are usually common colds, viral rashes, sore throats or tonsillitis, ear infections, where they sometimes discharge their ears, children cry, and very miserable, and you find that they've got a sore ear. Then you have perioptocellulitis, the swelling on the face. Sorry, I don't have a slide. I was going to put a slide in for that, but I didn't get around to doing it. Chest infections such as pneumonias and viral wheezes, skin infections, as already said, in impetigo, sometimes cellulitis, which is just a swollen red lump or area, urinary tract infections, meningitis, sepsemia, and malaria. Now, talking about urinary tract infections, usually a child under 1, if a young child or boy has recurrent urinary tract infections, we get very worried because it could be he has an underlying problem in the development of the structures of the urinary tract. And this can actually damage his kidney, give him long-term damage. So we're actually very keen to pick up those background problems that might happen. So if a child has urinary tract infection, I'm not saying most children, it's all right, it's a one-off, but if they're having recurrent ones, or usually under the age of 3 months, you want to have further investigation done by a doctor. Likewise, meningitis and sepsemia, these are things that we need to, these are nasty infections that we want to make sure we deal with. Everybody's worried about febrile seizures, and I'm just going to play this video for you to give it a bit of understanding that febrile seizures are actually not, they're actually benign. Let's see if it will play.
Sound is not clear. There's no sound.
It's none.
Mm-mm. It might be easier. It might be easier to open it in YouTube and then share from YouTube. Then you'll be able to share the sound. Yes.
All right, I'll do that later on. Let me just continue. Okay. I'll do it. Right. I'll come back to it.
Mm-hmm.
Now, lots of parents complain of coughs, colds, wheezes, and persistent coughs. Very common in children. And as I already did mention, even in babies, it's very common. Children tend to have coughs, which are usually driven by viral infections. And I'm sure you've all heard about bronchiolitis, viral wheeze, and asthma. Usually under the age of 1, you're diagnosed as being bronchiolitis. Between 1 and 5 is viral-induced wheeze, and then asthma, usually above 6. So we don't actually tend to diagnose children under the age of 6 as asthma, unless there's a strong family history of asthma or allergies in the family. Most often, viral-induced wheeze, as I said, if you look at this diagram here, you'll find out that these are the airways, and these are the lungs, the alveoli, the alveoli in the lungs. This airway, when you have a viral-induced wheeze, it affects the lining of these tubes, and it narrows. So if you have like a swelling on the skin, it gets swollen when you have an infection. Also, likewise, within those tubes, it swells up, and it narrows it reduces the diameter of those tubes, and it's like you're blowing air through a whistle. That's what gives the wheezing sound. And you can find most often they'll ask you, most children, they'll have to give them an inhaler with a mask, which will help with the salbutamol, which will help ease that constriction, will actually relax it and make it much better. And most children with bronchiolitis don't respond to this inhaler, but children with viral-induced wheeze and asthma will respond to it. So cough, colds, wheezes is likely due to viral infections. There's something called RSV, respiratory syncytial virus, and that's the commonest one, but the other viruses that also cause this as well. And usually if you get them to open up the airways, the children get better with time. Talking about fevers, lots of children have sore throats, and these children tend to have, they're off their feet, they don't eat, they have a fever, they don't like eating because pretty much the sore throat is actually very painful. That throat is very painful. And giving them just lots of fluids and some paracetamol tends to settle it down. Obviously, this tonsillitis, which produces the so-called strep infection. I know there were outbreaks in the UK last winter, and I think there's also this winter coming up as well. And we have a lot of coughs on the tonsils. And this is the type of sore throat that needs an antibiotic, penicillin usually. And we always nice for us to check our throats. The doctors, I tend to get sore throats every year. Asking kids to open up their throats, look at their tonsils. But yes, these children tend to need a course of penicillin for treatment. Talking about impetigo, already talked about impetigo, it happens in young preschoolers as well. You see this child's crusty nose, and this is a child with just lesions that are crusting. These children need antibiotics, usually due to strep and staph. And then talking about the exanthemas, the one on the little child with weepy eyes, red eyes, that's measles. So if you don't get your MMR or your measles vaccine, you're prone to having a child with measles, and this can be nasty. Children actually die from measles. So it's important to get your vaccines. This other one is chickenpox. Chickenpox is a mild disease, supposedly. I guess there's a few children that become unwell, but majority of them, it's a mild disease. And people, when they have outbreaks, they rush to this chickenpox party so the children get all the chickenpox once and for all. Most often it's just once in a lifetime, although a couple of children had one or two have had the second bout, but for most majority, it's a once in a lifetime infection. It's also extremely important that you get chickenpox before you get pregnant, because if you've had chickenpox, then your baby is covered. But if you have chickenpox in pregnancy, particularly around delivery, then your baby might be prone to nasty, nasty chickenpox infections. So it's important. That's why abroad, as the UK, the US, they would actually do the immune status of the mom to find if she's actually been exposed or not. And finally, hand foot. Hand foot is a common foot mouth, is also another viral infection. It's one of the Coxsackies, big word. But it's also a mild infection, which tends to be self-limiting, and the children are a bit miserable, have this rash around the mouth, around the feet, hands and feet, and I have around the perineal region, around the anus as well. But within a couple of days, tends to settle down. Talking about the nasty infections, meningitis, septicemia, depending on where you are, several bugs can cause meningitis, but the one that everybody screams alert in the UK is usually the meningococcal meningitis one, which there is the bleeding into the skin. These children tend to be miserable, irritable actually. You bend their necks and they cry and they startle, they don't like light, the fevers are raging, and it is life-threatening. You can see the picture there of the black child. It's not very easy. So you need to know your child. And even when you take the children to the hospital, you have to tell the doctor, depending on where you are, and in Nigeria, it might be easier. But if you're in Europe or in the US, you have to tell your child, that is not my child's skin, and I'm worried. And then the alarm bells get set. So I think it's important that you're aware and that you're informed, so that you need to inform those around you that you're not happy with this child. And that's a glass test in the white skin, and you see the rash doesn't disappear. So meningitis is actually an inflammation of the lining of the brain and the lining of the spinal cord to cause a little irritation and can be life-threatening. As we know, meningococcal meningitis, you can lose your limbs. Also, deafness comes along when it comes to meningitis as a risk. So and tell you when it comes to meningitis as a whole, I don't think, personally, people will not, there's always residual effects, no matter how minimal they are when it comes to meningitis. And talking about malaria, yes, we're in Nigeria. Malaria is, everybody has malaria when it comes to fever, and that's not true. So it can be very confusing, but we need to actually rule out malaria for everybody that has a fever with no focus. So obviously the child has a sore throat, and you see the tonsils are full of pus, then you know that's the reason for the fever. But if you can't find a focus, then you have to go and look for it to see if this is malaria or not. Yes, we feel we know the symptoms, but in Nigeria it's all about malaria, typhoid, and nothing else. And as a result, many people do die from it. The symptoms of malaria are usually fever, headaches, vomiting, fever, nausea, and dry coughs. It's similar to all the other things that we'll be discussing. But we need to take your child to the doctor and get a blood test done, a rapid test or a malaria parasite film test, and have to get treated. When it comes to the severe forms of malaria, particularly in children, severe anemia, when the blood counts crash. Child becomes very unwell, very pale, tired, and listless. And also when it comes to cerebral malaria, they're unresponsive and they can convulse as well. So it's important that we're aware that malaria is a diagnosis wherever you're in the world. Unfortunately, there are lots of kids that go on holidays to the UK, go on holidays from the UK and US to Nigeria, and end up coming back and becoming unwell, and very unwell with severe malaria. So it's important that we're aware that children have to take their prophylaxis. Prophylaxis is Malarone, which I know it's expensive, you have to buy it on the private market, but it's important that you actually get prophylaxis before taking your children abroad. The under ones cannot take Malarone, but so you have to cover them up and look after them properly. But most others, you can actually treat them. Talking about reflux, already talked about the colicky baby. I found in my practice that there are lots of babies that have reflux as a differential diagnosis for colics. These are children who usually around that 4 to 8 weeks become very unsettled, they're crying, they're spitting up clotted milk, so clotted milk, they squeeze their face as if there's something within their mouth that is sour. They pull off the breast at times when they're breastfeeding or bottle feeding. They arch their back in pain. And when you lay them down, they become unsettled. So these are the things that tell us this child might have reflux. And when they're in pain, they gulp up air as well. So they open up their mouths in pain, they gulp up air, and this rumbles down their tummy. And there are more and more cases. It's now a diagnosis that we actually make in clinical practice, and it's actually altered the whole outcome when it comes to reflux. Before, 20 years ago, when I was in the UK, there was a kids who had reflux up to the age of 9 months. They had, because of the pain, they'd never eat. And then they have to go for all these pH studies because they kind of damage their tummy. But now we're diagnosing and treating these things early. And you can just see this picture of the stomach. A normal stomach, the sphincter closes. And when the stomach is lax, the acid, so the lining in the food pipe is different from the lining in the stomach. So the lining in the food pipe is non-resistant to acid, whereas the lining in the stomach is resistant to acid. So when this acid, we know that this acidic, the stomach produces acid, it jumps into the esophagus, pain happens. And that's what causes the baby to cry. So basically what we tend to do, we tend to give thickeners to actually make this thing sit in the tummy. This is actually a developmental thing, so with time, this gets better. So by the time the child's about 4 to 6 months, it gets better. The tone gets stronger in that area, and the reflux becomes less of a problem. And once the child starts feeding at 6 months, it doesn't exist. Talking about cow's milk intolerance, that is something that goes hand in hand with reflux. So what you tend to do, we first treat the reflux. And if that persists, then we start thinking of cow's milk intolerance. And then this kind of kids taking some special milks to get on for them to continue to grow. We tend to tell moms that if they can be dairy-free, so they reduce their dairy intake, well, they completely remove all dairy products such as milk, cheese, and all the rest, and so the mother, they can breastfeed, and that also works for those kids. So reflux is the big problem, but we have standard treatment for it. Now, talking about diarrhea, constipation, these are two things that are very common. Diarrhea, we all know, actually, I think, quite frankly, Nigerians are very good at giving Diarrhelite. And that's it. If a child has diarrhea and vomiting, we tend to give the Diarrhelite, the ORS or the Diarrhelite, and nothing else. We don't give antibiotics, but it worsens diarrhea. We don't give anything else but the diarrhea, except for the Diarrhelite. And I know in Nigeria, zinc is also part of that preparation as well. And over time, small amounts are given, and over time, the child gets better, it all settles down. Constipation is another thing that is common. I don't know whether it's I don't think it's very common in Nigeria, but very common in the UK, the US, because of the processed foods that they take. And it can be a big problem. Children come in having been constipated for months, and find it very difficult to actually move their bowels. Sometimes for weeks, they're not moving their bowels. And it's a vicious cycle. So what happens, the child just constipation, finds it difficult to poo, eventually poos, and develops a tear, passing big poo, and now associates pain with passing poo. So each time he wants to go, he feels like pooing, he holds, and the poo gets bigger, and also bulkier, because the longer the poo stays in the rectum, the more fluid is absorbed, and it gets really hard. And so to break this cycle, we have to make sure that we get the poo out, flush it out. We have to act, this is call it disimpaction management treatment, and we give them Movicol or lactulose to get rid of the poo. But we have to continue that for at least a couple of months, because like when you stretch you have a pair of pants and you stretch it for 2 weeks, it's not going to jump back when you release it. Likewise, the bowel is very floppy and very loose. It's lost all its elasticity. So we tend to say that you need to give this Movicol every day for the next 6 months to make sure you can get the tone back and the child can get on with life. Eat your sore bottom. You have to eat your sore bottom. What is it? Is it worms? That's a big thing. It could be worms. And usually you have sometimes you have an infection in the vulva of young girls. It's usually a strep infection. It's really nothing to worry about. And such children, if you do a swab, it's usually strep or staph that grows, and you can treat it with a course of antibiotics. Likewise, little boy can have some pain, redness around his foreskin, and in that case, it's usually also an infection as well. And that sometimes just requires a couple of creams, antibiotic creams, or fungal creams, or sometimes it's a course of antibiotics as well. Worms, pinworms, very common. Worms, ascariasis, common in Nigeria as well. So children should be regularly dewormed and treated. Talking about the fussy eater, we have children that are fussy. We just don't eat. And weaning is very important. We need to know how to wean a child. If you miss that opportunity to wean a child properly, then it becomes an issue. And it's important that we use the proper weaning foods. There are lots of literature around for how to wean children at different stages and at the right, all this Indomie that people use. It's a whole lot of rubbish. It's not good. We need to begin to actually, we have got good foodstuffs. We start preparing lots of food for these children at home. If a child is a fussy eater and the child doesn't have the right nutrients, then we always worry about iron deficiency. And if there are lots of kids around 2, 3 were iron deficient, once you start the iron, replace the iron, the appetite actually improves. Obviously, if they're very, very iron deficient, they become anemic as well. And finally, I'd like us to talk about the HPV discussions, the new human papillomavirus vaccine, which has entered the Nigerian EPI schedule. It prevents cervical cancer. I don't think we actually used it properly in terms of the public awareness, but it's something that is important and protects the girls who will become women in future. Thank you.
Thank you very much.
Yes.
Go on, you were going to say something?
No, go ahead, go ahead. Let's answer the questions now, see if I can get the video.
All right, okay, all right. Just stop sharing for me, please. Thank you, Dr. Ajayobi. If we have any questions, you can put your hand up and then I can ask you to unmute, or you can pop it in the chat. Any questions or comments on any of the presentations? And the last one we just had. All right. Dr. Lumide, go ahead.
Thank you so much for your presentation, Dr. Dan. Great job. I just wanted to just, I'm sure a number of folks know this, but I'm just going to throw this out there. I find that mefloquine is a great option for malaria prophylaxis for folks traveling. And also based on the fact that it's a once-a-week medication as against some of the other options that you have to take every day. So for mefloquine, you start 2 weeks before you travel, 1 tablet per week. And then when you continue while you're away, and when you get back to when you leave Nigeria, you continue once a week for another 4 weeks. So I found that to be efficient and also more practical, I would say. Thank you. Well done, man.
Thank you. Any other comments or questions? Just raise your hand or put it in the chat if you have any questions. All right. Let's do the Q&A panel. I'm just going to ask all the speakers to put their video on. If they can, then I can put you all together. Just give me 1 minute. I think Dr. Orode is back as well. All right, so there's a question in the chat about cod liver oil. And cod liver oil, how effective is cod liver oil in cough and catarrh treatment? Does anyone want to take that? Any of the speakers?
Yes, so the thing about cod liver oil is that we are doing our best to actually not prescribe cod liver oil under the age of 6 months. And the question is for the speaker, what do you hope to get out of cod liver oil when you give it to a baby who has cough and catarrh? A child who is coughing and has catarrh, if they drink cod liver oil and they aspirate, we're all in a bad place. 1, 2, and they can do that when they're coughing. Cod liver oil, I don't know if you've ever taken it, it's horrible, right? So it's not the thing to even give at that age. First of all, there's no need for it. And then to what end? So what we find is that if you help the baby, if you hydrate and you help the baby continue to breathe with ease, they will overcome it. And so I haven't seen any studies. If you have any, please share with cod liver oil. It's useful. But I know that just as the Academy of Pediatrics and Pediatric Association, we're discouraging the use of cod liver oil, certainly under the age of 6 months. And we're encouraging that mothers are giving vitamin C drops and then treating the symptoms of coughs and colds. I don't know if that's right. I would like to add anything.
Yes, I agree with you already. Cod liver oil, I don't have evidence that it works. I I look at there are a lot of things that have evolved with time. So cod liver oil is something everybody used probably in the 60s and 70s, and it's moved, things have moved forward. As much as possible, it's important that we reduce the amount of things that we give these babies. Babies are endowed. They've come with, with a good stock. I don't think anybody has looked at it to see what's in it. I know the things on it, but actually looked at what is in it. It's an oily preparation, and as already said, aspiration is a big issue. And that is that this oily product gets into the baby's lungs, and it sits there and becomes a source of infection and reaction. Some reaction. So I wouldn't use cod liver oil personally. It'd be nice to ask this person why they asked that question.
Please, could you just explain what aspiration is? Because we have lay people on the call.
So aspiration is that when what you take goes down the wrong passage, it actually goes down into the lungs instead of down into the tummy.
Thank you.
So yes.
Okay, there was a question earlier about nospermine. What do you think about the use of nospermine in the management of colic in babies? I don't know what's in that product.
All right, I leave it to you, nospermine.
I think she's trying to unmute. Okay, yeah.
Going on. Okay, now it's fine. Again, I answered in the chat actually earlier that we discourage the use of drugs that we cannot vouch for. And if you look at nospermine is an anticholinergic. And what it would do is that it would reduce forward movement of the guts. The problem with that is that you end up with constipation, right? But there's no evidence that colic actually means that the tummy is rumbling or is moving too fast. What we know is that in some babies, they appear to be gassy when they have these colicky episodes. But we also know that most babies have colicky episodes and they're not necessarily gassy, right? So colic itself is, and I think it's just, I don't know whether to say this, badly named, because when you think colic, you think belly. But it's because babies are drawing off their feet, screaming, stretching. That's what babies do when they cry, right? What we do know about those episodes is that just the same way they came, they go. And it appears that it has something to do with their immunological / developmental, something is going on there, and the baby appears fine after a certain period. So you will notice that we don't make a diagnosis of colic after the age of 3 months, because developmentally they've gone beyond that stage. So for us, you don't want to put a drug into a baby that makes things worse. Now, the other drug that I've seen a lot of people talk about is simethicone. Simethicone is more recently now. Before, we used to see it, simethicone with Benadryl or simethicone with Piriton. Now they've gotten wise and they've said they're using it alone because they realize that pediatricians are saying, look, if it has alcohol, Piriton, Benadryl, please don't use it. So they're using it alone now, and moms are trying to, and the evidence we have of it is that it causes diarrhea, but appears to help them get rid of gas. Don't know if that's what's causing it. I always feel safer. I say if you use it and the baby is fine, then it's okay, right? But if you use it and the baby is not fine, and it was something related to whatever it was that was causing you, and you were trying to treat colic, but you ended up not treating whatever it was that was actually good, or you missed what was going on, then we have a problem on our hands. So as much as possible, once you've diagnosed that it's colic, when you've said, okay, this baby is doing this screaming thing, just do all of these other measures. What I find is that a lot of people are lazy around doing what it will take to help calm the baby down. Most babies will calm with many of these things. And after the age of 6 weeks, actually, some babies will come with a pacifier. And again, we say, we're worried about using a pacifier before the age of 6 weeks. But if it will help the baby after the age of 6 weeks not get nipple confusion, then that may be what you need to do. Okay, so I would just be careful about drugs in newborns and where we don't have evidence.
All right,
just
thank
to add
you.
that in the UK, the whole, similar drugs like Infocol and Colileve are used. We don't prescribe it. Most of the doctors don't prescribe it, but mothers will go to the chemist and buy it because of Colileve. But there is, as you said, there is an colic reflux can be a bit sometimes difficult to differentiate. But it tends, what you find out is that in colic it's appearing, reflux actually is appearing. Thank you.
Thank you. Dr. Olumide, you had your hand up.
Yes, ma'am. I just wanted to chime in. I think also as physicians, we kind of struggle now with a lot of varying and contradictory sources of information, especially online. So that as much as we have a lot of the expert knowledge in a sense, we also have to contend with other knowledge sources within the space. So what I try to do with some of these things is, number one is it clear that this thing is not harmful, that it may not be highly beneficial, but it's not harmful. So I try to entertain that in my advice and recommendation to families. So for example, for cod liver oil, as people have mentioned, I remember growing up with getting cod liver oil. All my siblings, I saw my mother and my grandmother literally give them cod liver oil every single day. So it becomes a challenge, of course, to fully discourage it. But part of it is now the fact that yes, it's not really high, it's not really necessary, but there are resources that speak to certain benefits of it, which is in general that the belief that it can boost the immune system and reduce the incidence of colds. Cod liver oil contains a lot of vitamin A, vitamin D. It also contains some omega-3 fatty acids. And that is believed, that's not even believed, that has evidence that it reduces the risk of rickets. So there's just a balance, that we, but also those benefits are still hard to measure, effectively. So, so in engaging parents, sometimes we kind of, in framing the response that, yes, this could be beneficial, but may not, be necessary, that type of thing. And then for colic, I find the most effective treatment for colic is TLC, tender loving care. But there are parents who, many parents want something, they want to do something, for them to accept that they won't do anything is a struggle. So there are some that will come in my office and they really want to use gripe water. And gripe water doesn't have, strong evidence to support it, but not entirely harmful. So sometimes I say, well, yeah, you may want to try it, but, there isn't much evidence to support it. So sometimes I try to use that kind of approach. Thank you.
Thank you. Thank you. Go on. Yes.
Can I just mention gripe water? Some gripe waters have alcohol in it. So I think it's very important that you make sure that the gripe water doesn't have alcohol in it. So some of these preparations do have, probably in those days, alcohol was put in so they could sleep. So for me, I tend to be careful about avoiding drugs as a whole, if possible. You're aware that there's lots of fake drugs around that have been a problem globally, not only in Africa. And so the less you give that is not necessary, the better.
Thank you. Thank you so much. Mr. Luke, you have your hand raised. You want to go ahead and ask your question? Okay, while he's doing that, a question about pacifiers, also known as dummies. Yes or no to the use of them? Who's going to take that? Use of dummies.
Yeah, so I think one of the natural responses of children is what so doctors will call I don't want to use a medical term, soothing that doesn't have to, sucking that doesn't have to do with feeding. Babies like to suckle, that's one of the main things that they do. So using soothers is not harmful, and yes, it's quite common, and yes, definitely it helps to soothe the baby to suckle and help to to calm them down. So nothing wrong in using them, but also just maintenance, using them appropriately, making sure that they're clean, and also knowing when to stop using them. Also at the same time, not to be too dependent on them, because their parents are literally struggling to, for 24 hours to keep the soother in. So there's a healthy balance to it as well. So that's what I'll say to that.
Okay. Any known effect on teeth, on the development of teeth?
Well, the part of what some, is in some literature, and what some of the dentists say, is that sometimes it can affect, the development of the jaw and things like that. But to be honest, I don't think, I'm not sure just how big that kind of effect is. But I think just in general, a level of moderation with such, it's reasonable. But to say, oh, never use a soother, I wouldn't even push for that.
Okay. All right. Dr. Orode, did you want to?
Yeah, I would just say that again, after 6 weeks of life, it is easier to allow parents to start. So, so what we're trying to do is establish healthy breastfeeding practices. If we start to use a pacifier before 6 weeks, it may interfere. So usually I'm again engaging parents around what do you want to use a soother for, so that we sort of understand. It's because everybody buys them with their baby bags, then we can encourage them. There's no need for it. There are some children who really need to be soothed. There are some children who self-soothe. And I think you have to know your baby. If your baby needs a pacifier, and I had 3 children who had different needs, and the first one was attempting to suck her first 2 fingers. I took them out and she was fine. The second one just stuck his thumb in his mouth and carried on for 5 years. And the third one would be very calm and then would cry. And if you pop a pacifier in his mouth, of course, by the third child, you're ready even for the dog to pacify your baby. So, but he was fine with it. Pacifier, and he took it out to talk. So after a while, we had a conversation. I said, "Can you drop the pacifier now?" He said, "Okay." He was just a little over a year old, and that was it. So again, it's about knowing the child. I do not advocate for pacifiers to be used under the age of 6 weeks. I am careful to ask mothers, what do you need it for? What does the baby need? Are there other ways? And there are some children who just feel the need to be suckling without feeding, and we identify and then help. I think the worst dentition issues actually are with the thumb suckers as opposed to the babies with the pacifier, because you can get rid of a pacifier, but you cannot get rid of their thumb. So you've got to sort of think about all of those things. And I just say, I don't throw blanket statement, but I certainly do not advocate before the age of 6 for any baby use a pacifier. Otherwise, if you are attempting to breastfeed that baby exclusively, you most likely will fail because nipple confusion will set in.
Okay, thank you. Dr. Ajayobi, do you want to add anything to that?
No, I don't have anything. I agree with it. Pacifiers, I mean, I guess it's difficult. I think you have to be able to discuss with parents. I agree 6 weeks, not before 6 weeks, but we need to just discuss with parents and come to some form of understanding as to, does this child need a pacifier? And if so, well, go ahead. I know that kids can drive you off the wall.
Indeed. Great. Thank you. Mr. Luke, are you ready to ask your question or make a comment because you had your hand raised? Okay. We have a question in the chat. Kindly shed more light on the routine use of antibiotics in children, especially Ampiclox drops in neonates. Some mothers believe strongly that the neonate should be given Ampiclox drops.
There's no such thing as use of antibiotics. Antibiotics should have a clear indication. If there's a specific infection that is being treated, then that is when antibiotics come into play. So it's not a routine thing that we know that needs to be administered for any reason. If a child has an infection, if there's something going on, then antibiotics will be recommended by a physician based on what is being treated. But just giving a baby Ampiclox drops is not recommended.
Can I just add into that? Unfortunately, Nigeria is a complex country, very, very complex. I trained in Nigeria, and I also did my residence in Nigeria. I did my youth corps in the General Hospital in pediatrics. And I know what operates. You know, they actually tell them, the mothers, to bring a small basket full of things for the babies when they're going to deliver. And in those days, even in the 90s, Ampiclox was part of it. There was the shawl and the hats and everything else. There was Ampiclox and other things. So it is historical. These things actually sit within the health system and things that we need to actually stop from happening. Even the care of the newborn, the whole guidelines for care of the newborn, they give erythromycin eye ointment for the eyes for every baby that is born. We're talking about antibiotic resistance in the 21st century, where antibiotics will not work. So you have a baby who has pneumonia, you give them the routine antibiotics, and it will not work. So as far as I'm concerned, it's the diagnosis has been proven that this child has a bacterial infection before you start giving antibiotics irrationally. Sorry. So it's very important. This whole thing of antibiotics, we are destroying our ecosystem.
The other thing I'll quickly add to that also is that sometimes we just good in breaking, as we break down the information for parents, that this child doesn't need antibiotics. And please, if we use antibiotics when it's not necessary, God forbid a time when the child actually needs the antibiotic will not work. You know, those kind of messages I believe are helpful.
And that's one reason why we want you to immunize your babies. So immunizing your babies, children don't come down with infections and therefore don't need the antibiotics.
Thank you very much. If you have any more questions, please pop them in the chat or raise your hand. And while you're doing that, we'll just have a quick message from John, the project manager for G Intervenes, and then we'll come back to the questions. We'll give our speakers a bit of a break so they can get some water or something. John, over to you.
Good evening, everyone. Good evening, everyone. Can you hear me, Flora?
Yes, we can hear you.
Okay. Let me share my screen. So good evening, everyone. My name is John Akere Sangodo, and I'm the project manager for Jintivins Healthcare Foundation. I'd like to give a vote of thanks on behalf of the entire board of trustees of Jintivins, as well as the management staff. Usually at this time, we thank you all for coming and for joining us on this call and staying to the end. But we'd also like to give you, for those of us that just seen us for the first time, a little more information about us, what we do, and how you can support the cause. So Jintivins is a health-focused non-profit set up in 2018 to conduct humanitarian interventions in the healthcare sector, in the healthcare space. Our interventions take various forms, different forms, but sometimes they're virtual like this public talk or webinar. But most of the time they're in-person and physical interactions where we interface, the organization interfaces with the members of the public and patients as well. But whatever the form that these interventions take, they're made possible by charitable donations made by well-meaning individuals and organizations. So it's in the spirit of this, we ask you to consider making a donation to our official account, Stanbic IBTC Bank. I'm sharing the details on my screen. So it's Stanbic IBTC Bank, Jintivins Healthcare Foundation, account number 0028901410. I say the account number again, 0028901410. So at this point, I'd like to say a very big thank you to our facilitators, people that do 1,000 things behind the scenes to make interventions like this possible, our sponsors and our perennial collaborators. We'd also like to say a very big thank you to our speakers who have made excellent presentations today. They were engaging and compelling as well, even the videos that we watched. We'd like to say a very big thank you to you for giving us the benefits of your time, your experience, and your expertise as well. In the event that you joined us maybe for the first time, you might not be, well, most of us are already aware that this session is being recorded. So it's going to be uploaded to our YouTube channel later on today or later on tonight. So in the event that you missed anything that the speakers were talking about and you want to watch back any of the things that you might have missed, the opportunity is there. All you have to do is go onto YouTube and search Jintivins Health Foundation. You'll see some of our videos, not just today's video. Of course, you can watch back this evening's video, but we also have a catalog of content of other health talks that we've had in the past. We'd also like to say that please like, share, and subscribe to the channel so that the channel grows, and we have opportunities also to share broadcast the message that that Jintivins has. So we'd like to say a very big thank you for staying to the end. And even before we continue the questions, we say thank you again from wherever you're calling in from, and enjoy the rest of the evening. Thank you.
Thank you so much, John, for that. All right, so Dr. Orode wanted to make a comment about the last question we were talking about. So I'll just let her do that.
So thanks a lot, and thank you to Dayo and Olumide for really explaining some of the complexities of what we face as doctors and pediatricians working with young children, newborns, and young infants in Nigeria. I think the other thing is that I'm finding more and more that many young children are coming back from a visit to the doctor with antibiotics and antimalarials, both prescribed for a child with perhaps a low-grade fever, cough, and catarrh, very consistently. If 9 of them go to hospital, 9 of them will get antimalarial and antibiotic. So as much as possible, I find myself discouraging them except they have a high fever. So if mom calls and says, baby has a temperature of 39.3. If they tell me, oh, the body is hot, I say, what's the temperature? They say they don't know. I find myself discouraging it because I know they're going to go and get an antibiotic and an anti-malarial. And we have to start to talk to ourselves as well. You know, I'm glad for Ampiclox or Amoxiclav being 57,000 naira. I'm glad because it's discouraging people from unnecessarily prescribing. But what's the thing? Why do we have to get to that? So I think we've got to figure this out as well among ourselves as professionals. What are we allowing young medical officers to do? Is this is this because they have insurance and they can get charged? I don't know what it is. I think it's wrong. We need to call it out. And we're certainly calling it out at the level of Pediatric Association, but just for other colleagues as well as other mothers. Mothers should know there's no need for a baby to get antibiotics. Don't ask for it. It will become apparent if baby needs it. But don't go asking for antibiotics. It's causing us problems. So thank you. That's what I wanted to add. Thanks.
Thank you very much. Thank you. Okay. Earlier on in the program, we'd had a discussion about resuscitation in babies. And we can see there are more people on the call now. So we just wanted to refresh and talk about that. I will just show you the short video just to reinforce and emphasize the points before we have our final comments. Dr. Olumide.
Yeah. Before I get into that, just quickly say, I think the expression that we often use in medicine is what we call antibiotic stewardship. And I remember in training, they used to, teachers used to really strongly emphasize that. And I think definitely there's a place for that in Nigeria. I think within the circle of pediatricians, you know, on average, perhaps you'll see better stewardship. But I think it's important to engage other physicians. For example, I think there's nothing wrong in pediatricians talking to other general practitioners about the importance of better antibiotic stewardship. And then more and more, especially for Nigeria, it's so important for doctors to get out of the office and get out of the hospital and actually engage the community better before they come to us with, you know, a lot of it. There's so much need for more education. I was going to mention to Dr. Doherty and Dr. Dayobi. I watched a recent interesting presentation from a developmental pediatrician who's based here in Canada. And what him and his team were able to do was actually start an Instagram type channel, 1 minute health education talks. And he's originally from, his roots are Indian, but I think he grew up here. And so he went on to create a channel in the Punjabi language, then now did one in another language, Indian language they call Tamil. And so it works in an academic institution. And of course, for people who are working in an enabling environment, they got a government grant and now have more than 10 languages where they're running the channel in. And they are now in about 40 countries, and their videos they've had about 50 million views of their videos on Instagram. So, you know, really quite impressive. And as I listened to him, I could actually see the potential for something like that in Nigeria. But it just requires a lot of support and all of that stuff. But hopefully, there may be opportunity to do things like that. Now, so I quickly mentioned about what I said earlier. The organization I represent is called For Breath for Life. I'll just tap it in the group chat there for the folks who want to visit and learn more about what we do. And so we run different programs in Nigeria, and one key focus area is to train healthcare providers on basic neonatal resuscitation skills, basic essential newborn care, so that we can reduce the very high risk of our babies dying. And as I mentioned earlier, Nigeria has the second highest infant mortality rate in the world. And the core reason for this is a condition we call birth asphyxia, when a baby is unable to breathe at the time of birth. Most people actually know, or let me put it this way, many people don't actually realize that babies don't breathe when they are inside their mother because there's no need for breathing. It's when the baby comes out that the baby now has to initiate breathing. And sometimes for different reasons, a baby is unable to initiate that by itself. And so in our medical circles, we have what we call the golden minutes, meaning that within 1 minute of life, a baby should either be breathing on their own or someone should help that baby breathe. So we created a video to kind of capture what that reality is. And I'll share my screen now so you guys can see it. Thank you for your audience. So I'm sure most people here can get the import of what the video is trying to convey. And the essential point is that the death of a newborn can be prevented if a skilled provider is present at the time of that delivery. And as they say, now that we're at Christmas time, when they say, go tell it on the mountain. So please, let's tell everyone, let's tell our friends, of course, ourselves aware, tell people, let mothers know that it's so important that they take the necessary precautions, regarding when and how they deliver, and to make sure that the providers that they're going to entrust their care to have the necessary skills to help them in case some of these scenarios develop. So thank you for your audience.
Thank you very much. I've posted the link to that video in the chat, so feel free to share far and wide.
Could I just ask, please? I think we should have a discussion. Do people actually know what this video means? It's open to everybody. But yes. I think, do they know what this video means? I'd like to have some contributions from the audience.
Okay, I've allowed everyone to unmute. So if you would like to speak, just raise your hand and then let's have a discussion about this. Just a short discussion. Any comments about the video? No comments?
I'd like to just say there are 4,000 private hospitals within Lagos State and 400 government hospitals. Then there are lots of people that go to traditional birth attendants to have their babies as well. This is Lagos alone. You can see that video showed a skilled attendant who had an ample bag. So the baby did not breathe. That ample bag was used to help that baby breathe. Have you asked yourself, when you go for deliveries, do they have this equipment? Are they skilled in delivery? Before you have your baby, you're asking that question. Are they skilled? If my baby doesn't breathe for any reason, you have the skilled person and the equipment to make my baby breathe. This equipment is very simple. Are you telling your friends that need to ask this question when they register with a facility? As Dr. Efeson said, and Dr. Edward has also said, we've discussed this, we're actually going down to the level of training traditional birth attendants to do this as well. He said no child, we said no baby should die from birth asphyxia. They don't deserve it. And something just requires a gentle maneuver, a few, just applying a few, resource tracking, yes. And that child will come around. But if that doesn't happen, that child will be brain damaged. That's how bad it is. So we're asking, and this, this is not just at the people who do not have the money. It happens in big institutions as well. High-level institutions. This big issue. And that's why I'm asking, do you understand what this video really means and how we can get it out there to mothers, your friends, and to whoever it is, your drivers who have babies, have wives, get it out there so we can impact. We are pushing, all three of us are pushing training in this area. And there are many others that are trying to do it. So that's just my comment.
And I'll just
we have DDLS. Okay, go on.
Just add something real quick to what Dr. Dad mentioned. And also it's important that to ask the question of your providers. What if I need a cesarean section? How would that happen? can a cesarean section happen in this place where I'm going to deliver? And some places can do that. But in addition, if it's not a place that can do a cesarean section, what is the plan? What is the emergency plan in case? How do I get to the place where it will need to happen? So that plan has to. So all of those things, that whoever is taking care of you needs to have a full understanding of all of that, so that we can activate the plan when needed. Not that when we're now in trouble, we're not scratching our heads. As simple as, what source of transportation is available for me to move from where I am to where I will get to the next level of care? Those are the strategic questions that have to be asked at the right time, so that we can prepare and anticipate, just in case of any complications. Thank you.
All right, okay. DDLS, please introduce yourself and ask your question.
Yes, my name is David Shoyle. I'm a general practitioner in United Kingdom. Thanks very much for the presentation, although I joined late. Actually, Dr. Ajayobi and Dr. Oyefeso kind of spoke into what I had in mind. And my gripe is that what we are presented is be available in most cities, or for our people who can have access to probably a health center or general medical center, wherever, where there might be professionals or even people who are taught on how to resuscitate. But I don't know the statistics, but I know that majority of our deliveries, I hope I'm wrong, is delivered in rural areas in the country where no access whatsoever exists for any kind of professional. There's that. So we need to, so this is kind of quite good, but it's too far-fetched, too high to reach for majority of the people. I hope my statistics are wrong. That is a majority of them delivering in rural areas by traditional health attendants, by relatives who have no knowledge of birth or delivery at all. And I think whatever we do, the For Breath for Life thing and things will be very helpful, directed towards this majority of the people. I don't know, but a lot of us in Nigeria live in the rural areas, not in the cities. And we need to aim at that. Thanks so much. Thanks so much.
Thank you, Dr. Shure. Thank you very, very much. We are addressing this issue. As you say, all three of us are we are very grassroots people. The aim is that we are going to train 250,000 traditional birth attendants at a grassroots level on resuscitating.
That's what I
and that's what we're doing. And we're going to train traditional birth attendants.
Right.
So this simple tools, we're going to train them. We make sure we can train them. We train them, and then we get it out there. Mothers are going there. Even within Lagos State, 60% of mothers go to traditional birth attendants. That's up to the north when it goes up to 90, 95.
Yeah.
Let me quickly add also that, Dr. Dai, were you done? I thought you were.
Yeah, I'm finished.
Okay, let me just add, so for example, for Breath for Life, we've been training healthcare providers in Nigeria for more than 10 years. And our focus is on the underserved area. We're not trying to be, we're not trying to do work in Victoria Island and all that stuff. It's really in the hinterlands that our work has been directed. And training is ongoing for traditional birth attendants, community health extension workers, nurses, midwives, and even doctors. You'll be surprised there are even many doctors that are not adequately trained with some of these skills.
Sure, absolutely.
So all that kind of work is ongoing. I'll be honest that there have been limitations, because really and truly, all of this stuff we're talking about, I don't want to get into that too much, but all of this stuff we're talking about is really what the government should be pushing to propagate to scale. But government cannot do it on its own. Definitely, we could do with a more efficient government that can do more. But even at that, government cannot do it all alone. Even in the most successful advanced countries of the world, the government doesn't do it alone. But part of the problem also is us, in the sense that when we see these bad things that are happening, we're not advocating for our own people adequately enough. Okay, you know, the fact that you don't have that problem doesn't mean that you can be oblivious to the fact that someone else has it. More than 60% of our women do not deliver in a hospital.
Absolutely.
More than 60%.
Yeah.
And then also you'll be glad to know that as part of our efforts, because there are many entities working in different silos. Some person doing a little thing here, one person doing a little thing here. But what we're trying to emphasize is that it is critical for all these well-meaning people to really start to work together, because the problem is bigger than what any one person can do. Sure. And I'll close with this in saying, this December, we're so excited because we now have partnerships in tents in Lagos, in Ibadan, Port Harcourt, Asaba, Enugu, Zaria, Maiduguri, Abuja, Kano, and Yola, and so that we now have partners, and we'll be having simultaneous trainings going on this December by the third week in December, which we have tagged December to Remember. So based on these partnerships, this kind of work is going on, and as long as we get more resources and rich people like you give us money, I think we have a chance. Thank you.
Thank you very much.
Andy will help me. Thank you. Well done. Thank you.
Thank you. All right.
I just wanted to add something.
Sorry, go on.
DDLS, thank you for your comments. Actually, the greatest number of Nigerians are not in rural areas, because we've had a rural-urban drift in the past decade and a half, 2 decades. So we have now large numbers of people in shanty towns and in urban slums, high-density urban areas, where people who are, whether it's internally displaced people or people who are seeking greener pastures. So the population of Lagos, for example, has significantly ballooned. That's one. The other thing is that, and Dr. Ajayobi always says this so well, I love it, I'm borrowing herself. People take with them their practices. So everywhere people are coming from, and they're coming to Lagos, for example, they're going and they're retaining their practice of going to a traditional attendant for delivery. That's the other thing. Now, the Pediatric Association of Nigeria every year, without fail, trains people in neonatal resuscitation, trains trainers, and those trainers go back and train across their states, right? So there are large numbers of people. But those people are all nurses, doctors, community health extension workers. However, we know, depending on which community you're in, that more women are delivering outside of primary health centers and general hospitals. There's a range of healthcare workers or individuals who are taking deliveries. And it is these gaps that people like Dr. Ajayobi are now seeking to close by making sure that the people who ordinarily would not be considered to have comprehensive, basic emergency newborn service now can provide at least newborn resuscitation. But I think that beyond that, it's also important for us to recognize that many of these people who are not even registered with the states. So we have the ones who are registered and we can identify them, but actually more are not registered and they're operating undercover. So it's not every behavior we should say, oh, train everybody. There are some people who their intention from the beginning is not to do the right thing. Some of those people have to actually be handled as doing bad things. But by and large, our interest is in making sure every baby reads at birth and we don't bury them on their birthdays. So the both rural and urban is important, and urban now much more so because of the population. The populations have gone really high in the urban areas, and those areas need to be addressed. So let's not all keep thinking everything is happening in rural areas. It's not. It's actually not. That's not what the numbers show us.
All right.
Thank you.
Well, thank you, Dr. Doherty. Thank you.
All right. Okay. So iPhone, you have your hand up. Please unmute yourself and introduce yourself and ask your question, please.
Yeah, hello.
Yes, we can hear you.
My name is Honorable Lawal Ayola, calling from Sweden. Basically, I'm a paramedical person, but working in the field of project management, business development. First and foremost, I want to commend the organizers and the speakers and all the contributors for the great session. Moving forward, I just want to know what those people that are in here that are practicing in the as pediatrician within the government settings are doing to improve the attitude of the nurses and the pediatricians in the public health sector. Because on the private side, nothing, I have to be candid, because I did my research very well personally and engaged a lot in Lagos State. Most of the doctors, hospitals are in for money, majority are in for money, And as the last speaker rightly, maybe the previous speaker before the last one, that most of these people, most of these mothers, the pregnant people are not, there's a lot of migration in the capital city, in the urban area. But most of those urban area, when you tag them urban area, is just by words. They are still local, I call it a semi-urban area. And most of the people, because personally, I've seen people that are, personally, I paid for more than 4 people giving birth at home. They call those nurses to come down, and even nothing, I pay for everything regarding what they needed to even deliver a baby and all that, even no clothes. Apart from that, my main question is, what are you people doing to change the attitude of even the pediatrician and the healthcare workers in the government sector? I'm not even talking of the private now, because the private is all about money. If you don't have it, don't come in. And the way they treat these pregnant people when they are coming back, mother that are about to give birth, on the average, the environment is not accommodative at all. Based on my own personal experience. Thank you.
Can I
Thank
just
you so much.
Honorable. Okay. I just want to say one thing.
Yes.
One plan that we are, one drive for us dealing with the traditional birth attendants is see how we can strengthen the links between the informal and formal sector. So we're actually working with Lagos State at the moment. And Lagos State has a traditional medicine board, and the TBAs actually come under that board. And so what we're trying to do is, even though it's under that board, the systems are still very parallel. So we're trying to strengthen those links. I agree with you that the big issues around healthcare workers, informal sector, and where they treat pregnant women, or even people in general. And I think that's one drive why many mothers are actually moving towards the TBAs as well. It's one of the reasons. But we can only begin to work at it from a very, very foundational level. And that's what we're trying to do, to try to bring them together so we can improve those referral pathways. So that's just me. All right.
Okay. Thank you. Thank you very much, Dr. Tayobi. And thank you, Honorable, for your question. So, in fact, you are spot on. I am currently implementing one project. It's called Project Aisha. Project Aisha is working in Ifakojaya Nekwe, just as a sort of springboard, but and in Kaduna State as well. But the idea is that a lot of studies have demonstrated that the attitudes of healthcare workers, as you have rightly mentioned, is a lot to be desired. I will be careful to say attitudes of pediatricians, because that's not what the data shows. The data shows attitudes of nurses, and so the interventions that we're carrying out with the states now are focused on identifying what it is that is causing us is to have these issues. Many of them are burnt out, underpaid, overworked, under-trained, under-supported, right? So we're addressing these issues with them is one. That's one area. The other area is that we are helping the nurse practitioners in the private sector also increase, expand their services in order to offer women with more choices, so that these are all registered nurses, so that the women can make a decision. I want to go and see a nurse in the general hospital, in the primary health center, in the community. There's one thing that makes people sit up is when they know they are being watched. The other thing that makes people sit up is when they know they have competition. And the numbers are in. Less than 20% in these communities are delivering in the private house, in the general hospitals and the primary health centers. Most of the people are now dealing with traditional birth attendants and with the nurses in the communities. And so they are also now looking up, sitting up, the people in the government hospitals and saying, what are we doing wrong? Because the numbers vary. Every month you look at number of women who come for ANC, number of women who actually deliver. Then you look at the same thing for all the other people, and you see the disparity is wider and wider every month. And so there's a lot of training, but a lot of also identifying what the issues are with the people in the public sector. The conditions of service are not great. They are earning far less than many of their contemporaries. Many of them don't get the opportunity to improve themselves when they start working, and sometimes they are overworked. So that's one area, attending to the needs of the nurses, providing some competition, but also ensuring that mothers can report. Mothers can say, such and such a thing happened to me at the hospital, and giving them an opportunity for feedback so that we can identify at source where the issues are. And technology is helping us do that. In Project Aisha, we have a system whereby patients can report. This happened to me. I went to Ijede, I went to Ekpe, I went to Agbole. I spent 3 hours waiting to see somebody. And in real time, we can address and say, this is one of the reports that your patients said about you. What happened? And they can go back and now that they know they are being watched, people are sitting up. So we can't only say, what are we going to do with the nurses? Because the patients too have a responsibility to stand up and fight for their rights. And that's why I love teaching mothers. I love telling mothers and helping them understand that actually they are the ones who empower us to go back with the feedback. Now they have to give that feedback as well. And then we're speaking with the communities, with the ward health committees, with the ward development committees, and really identifying where and how they can make things better in the community, to make the primary health centers more attractive to the women, to make the conditions of service better for the nurses and the doctors who work there. So, I just think of maternal health care as an ecosystem. And I don't want to choose for a woman where she goes to have a baby. What I want is for her, anywhere she goes, for her to have a safe delivery, for her to have good quality health care, for her to feel respected when she's receiving that health care, and for her and her baby to go home alive. And the way to do that is to identify everywhere where she could possibly go and make sure that they are given the best opportunity for care within their own resources, and then an immediate and effective referral, so that if there's a problem at the level of the traditional birth attendants, very quickly the woman can be referred and she can be moved up. So, and that means optimizing everybody's capacity and let the woman decide. And when the women themselves see who is giving the best care, women tell. They tell all the time. They tell their stories all the time. And, it's what I like is after that feedback, was there a change? Because if we give you feedback 10 times and you don't change any of the 10 times, you'll soon lose all your customers. And well, that's okay too, right? Maybe you don't want to be in that business. Maybe you want to go somewhere else. So I think also empowering the women is an important part of this. Thanks.
Thank you very much. And on that note, we are going to wrap it up. Unless there's one last question or comment. If not, we're going to wrap it up for today.
Let me throw one at you then, since you opened the door. It's just at the core, just really briefly, accountability is key. Folks, we have to hold people accountable. People that serve us, our leaders, people that work, they serve us. And that's what has helped the most advanced countries succeed. It doesn't matter that you're a big doctor or whatever, or nurse or whatever you call yourself. You cannot belittle another human being. In any sane society, they will hold you accountable. They will report you, and there will be punitive measures to bring you to action. That is the key. And we've lost a lot of that accountability for so many years. And I don't want to get into our politics, but that's the reality. If people who are in leadership position do not serve the needs of the people adequately, then they have lost their focus. And the people themselves must advocate so that the necessary dignity, and that's what one of the words that I use when I think about Nigeria, dignity. We have to give people have been robbed of dignity. We have to give them back dignity. Many of our people are not empowered to think of themselves as people deserving respect, and they tolerate so many things. People go to the doctor, they go to the nurse, they're afraid to even ask questions about their health. I say, no, you have the right to ask questions, and they educate you. Mr. Doctor, if you're going to give me a medication, the medication is going in my body. So I have the right to ask you about it respectfully, and you should respect me as well. So thank you so much, everyone.
All right. On the very last note, on that note, we'll say good night. Thank you everyone for joining. Thank you to all our speakers. The recording link was posted in the chat, but if you would like any more information, you can email Gintervenes at ginterveneshf@gmail.com.